Hello, my name is Stacy Sanchez. I am a registered nurse and a lactation consultant, and this is Welcome to Parenthood, the crash course. This is a perfect video to watch if you have just had your baby or if you're about to have your baby and you're finding yourself without the time to go through traditional courses and things like that. This is kind of like a really streamlined version, condensed version of all the information I have in my head from helping families for about the last 10 years. And I feel like it's a really great starting point, especially for new parents, because you don't know what you don't know. And this way, you can refer back to it, go through it when you need to, and follow the resource links in the bottom in the description box, kind of give you some more insight in the things that you need to know. The other thing is you can always feel free to reach out to me via email, and I will be happy to help you in any way that I can. So let's get started. So, as I said, this is Welcome to Parenthood, the crash course. My name is Stacy Sanchez. I am a registered nurse and an international board certified lactation consultant. I've been a nurse since 2010. I've been an OB nurse since 2015, which has been my dream since I was a 10-year-old little kid. I'm also a car seat technician. I'm an international board certified lactation consultant, like I said, and I also have four of my own children. My oldest was born in 2005 and my youngest in 2018. I have two boys and two girls. I also had the privilege of helping raise my four younger brothers and sisters. So kiddos are my hobby. So, as I said, our objective is going to be to get you the information that you need to get you started and prepared. When we know what to expect, we feel a little bit more confident, we feel a little bit more secure in what's happening. So, this will hopefully give you a good, well-rounded sort of foundation. So, then when you talk to your doctor or your other healthcare providers, you have a starting point in knowledge, and then you can ask questions. Because a lot of times when we see these people, they'll feed us a bunch of information and then it's all brand new and it's overwhelming. And then they'll say, "Do you have any questions?" And no, you don't, because you're overwhelmed and you don't know what you don't know and you don't know to ask what you don't know to ask. So the more you know, the more you can ask and the more you can continue to know. All right, we're going to kind of go in order of operations of how all of this starts. We're going to skip all the pregnancy things because we're going to stick with the very most important things that we need to know. And at this stage, you need to be prepared for labor. We will also cover C-sections a little bit, but even if you're not going to if you were going to have a C-section and you knew that it was planned, you still need to be aware of what labor is and how to tell what's going on with your body, because a lot of times when we have scheduled C-sections, the doctor does not want you to go into labor. And so when you start to feel these things, it's important that you go and get the care that you need. So labor is the process that a woman's body goes through to give birth to a baby. There are four separate stages of labor, and in each one of those, they have their own specific things. Very broad overview. The first stage of labor is the contraction parts that we are all very much aware of. Those contractions can go on for days, especially if you're a first-time mother. And, even if you are in the early stages of labor, sometimes you might not be aware of it because the contractions are pretty mild and you're handling them pretty well. And then the contractions will kind of pick up a little bit. And then finally, it'll get to the point where you can't do anything but focus on those contractions. That is your first stage of labor. After that, you're going to move on to pushing. You're going to push the baby out. You're going to deliver the baby. You're going to then deliver the placenta. And then there'll be the repairs that might need to be done. And then after that, you'll have your recovery period, which is about 2 hours. Whether you had a C-section or a vaginal birth, every healthcare facility is a little bit different. But the acute recovery period for both of those is about 2 hours, where you'll be looked after very, very closely. All right, and then when we get more into contractions, we'll talk about what you would expect when it is time to go to the hospital and what to kind of expect overall on a broad view when you do arrive to have your baby. So Braxton Hicks are contractions that are irregular in length and duration. These are what are also known as practice contractions. They're called Braxton Hicks because that was the name of the doctor who published information about it first. Usually when you see a medical condition and it has a person's name attached to it, it's because they were the first one to really pioneer information on it. So anyway, Braxton Hicks are just practice contractions. It's it's irregular. It's not going to be like clockwork. You might have a contraction now, and then maybe 10 minutes later, you'll have another one. 2 minutes later, you'll have another one. There's no really rhyme or reason or pattern. Sometimes they can be kind of intense, but if you lay down and you rest, you relax, you hydrate, and the contractions go away, then it was most likely Braxton Hicks, because true labor, it honestly, it doesn't matter what you're doing, you will not stop that train. Okay. Braxton Hicks also do not dilate or efface the cervix. Dilation is when your cervix actually opens up. Effacement is when your cervix disappears, because your cervix and your uterus, to begin with, kind of looks like an upside down pear. You have this round part, and then you have this little extension or peninsula type of thing on the end. That's your cervix. What effacement is that couple inch cervix is going to disappear until there is nothing left but a nice round uterus. So that's what dilation and effacement is. Effacement is it's going away. Dilation is it's opening up. Okay. These are practice contractions for both mom and the baby. And why are these important? Well, when you have a contraction, your uterine muscles are clamping down. That kind of stops the blood flow a little bit to the placenta for the baby, and that's your baby's lifeline, their oxygen and things like that. So we do these, your body starts to do these practice contractions so that your baby can get used to this, because for the baby, when the labor gets really hard, sometimes it's like kind of going underwater for them. And we'll talk a little bit more about what that looks like on those fetal monitoring strips. It's also practice contractions for mom, to see what your body is able to handle. I've seen a lot of ladies in the past who will have pretty bad Braxton Hicks, and sometimes they need to end up resting or doing what they need to do, so that they can carry their baby full term. Your body has a miraculous way of communicating with you if you let it. So we don't always want to just ignore everything that we go through. We also don't want to be hyper aware of it either. But just remember that your body communicates with you, and especially when you're pregnant, it is very important that you listen. All right, so true labor. These contractions are going to stay the same, or they're going to ramp up a little bit, no matter what you do. It doesn't matter if you rest. It doesn't matter if you hydrate. It doesn't matter if you get in a warm bath. Nothing you do is going to relieve these contractions. This will dilate and efface the cervix. You might even have a bloody show. And if that happens, that is okay. You don't have to bring that bloody show with you. Some people have brought me their mucus plug. It's okay. All that means is when you get pregnant and the baby starts to build its home inside your womb, the hole that it opens in your cervix begins to fill with mucus, so that there's a plug there. It actually plugs that opening so that your baby is protected from pathogens and all kinds of unwanted things getting into your womb. So when your cervix starts to open up and dilate in a face, that plug gets released. And sometimes there's a little bit of blood involved, because your cervix is dilating and effacing, and that's okay. A little bit of blood is normal. So sometimes people will panic about that. It is okay. If it's a little bit of blood, like spotting, even if it might even be a little teeny bit of a little pink stuff, that's okay. And unless you have bright red blood, or if it is flowing, things like that, then you might want to go get checked out. But if it's just a little bit, truly, it's okay. And if you're not sure, call your doctor. The doctors have an answering service. So even if it's not, office hours, you can call the answering service and they'll get you in touch so you can speak to your doctor about this. You can also call the place where you're going to be delivering your baby. If you call them and say, hey, I need to talk to a nurse, this is what I'm experiencing, they will also give you guidance that you need. Okay. You might also feel like you have like heaviness, like you need to go to the bathroom or have bowel movement with these contractions. That is also normal. That is your baby's head coming down and pushing on everything that's in there. And they might also be painful or uncomfortable. What if your water breaks? Well, if your water breaks, you want to make sure that you get to your birthing place ASAP. And you also want to notify or your provider so that your doctor is aware. And I know that it'll probably be exciting and there's a lot of stuff going on, but try to pay attention to what color is it, how much came out, does it smell, and about what time did it happen. All of those details are super important in deciding the best course of care for you and your baby. So we want to know, what went on when all of that happened. So in the midst of all the excitement, if you could try to remember these details, or you could take a picture, because it is 2024 and we have a camera with us everywhere we go. So at the hospital, so what I said I was going to tell you about the contractions. Usually when your contractions are about 5 minutes apart consistently, that's when your provider will inform you that you should be heading into the hospital. Now, if your water breaks, just go. It doesn't matter what your contractions are like, because once your water breaks, the clock sort of starts ticking and you could be an infection risk. And if you, one of the tests that they do at the end of pregnancy is they do a swab of like your private area, and they're looking for group beta strep or GBS. If you are GBS positive and your water has broken, they will absolutely want to start antibiotics right away to prevent an infection for you and your baby. So it is very important that if your water breaks, you go to the hospital ASAP. If your contractions are 5 minutes apart consistently, you also want to go to the hospital then so that you can get checked out. If you are in doubt, call the hospital, call your doctor, or call somebody, okay? So when you do arrive at the hospital, they're going to kind of go through an admission process. Depending on where you go, they might want you to stop at the front desk. They might want you to stop at the ER. It's important to know this stuff beforehand, if you can, at the place that you're planning to deliver. When you arrive, they'll get you situated, have you change into a gown, they'll have you sign some consent forms, they'll go over a medical history, and they'll do an exam and an assessment on you. They'll feel your belly, feel the contractions, they'll put on an external fetal monitor, and your nurse will most likely want to check your cervix. If you've never had a cervical exam before, they can be uncomfortable, but I'm telling you that they are made infinitely more uncomfortable if you are not relaxed. The doctor usually in the office at your last couple visits might check your cervix. Just so you know what a cervical exam looks like, your nurse will take 2 fingers with a sterile glove. There should be lubrication on the fingers. They slide their fingers in, and what they're doing is they're trying to find the opening of your cervix. And what they're doing with their fingers is they need to find that opening, and they need to see how much is it open. How many fingers can you or can you not get in there? And then the neck for the effacement. How much of that peninsula is left until we get to that perfect circle? So that's what they're trying to do. They're also trying to see how high up your baby is, because that is what they talk about when they talk about station. Station goes from +3, +2, +1, 0, -1, -2, -3. That all has to do with the position of your baby. And when you are in very early labor, sometimes your baby is up very high. That might be why it feels like we're really, really reaching. We're trying to touch your baby's head to make sure that your baby's head is nice and engaged and ready to be in labor. We're trying to see if you're dilating and opening and trying to check progress. There are tips and tricks that we could do for positioning to make it a little bit easier. If you have experienced trauma in the past, this might be, rough for you. Let your provider know, let your nurse know. Like, hey, I've been through some things and these exams make me very uncomfortable. Can we please take this very slowly? There is nothing wrong with advocating for yourself and letting your provider know so that they can take better care of you, okay? So that's a cervical exam. They'll also probably start an IV. Why do we want to start an IV? Well, even if you don't want fluids running, even if you don't want any of these things going, sometimes labor can turn sideways very quickly. And if something were to happen to your baby, you want us to be able to respond as quickly as possible. So that's why we like to make sure we have an IV line in mom, because I have seen us get in the back and get we'll go from a labor room to a C-section. We've done that in under 5 minutes. The only reason we can do that in under 5 minutes is because we already have these things in place so that if we need them, we can utilize them. Okay, so make sure you talk to your provider about the IV and what the expectations are for that. We talked about the external fetal monitor. Those are like the 2 little circle things they're going to put on your belly with straps. One of those is going to record your baby's heart rate. The other one is going to record your contractions and the mama's heart rate, okay? Again, about talking to your nurse about your expectations and fears. If you've experienced trauma, let your nurse know that. I have experienced trauma. This is very uncomfortable for me. You know, you're about to be very exposed with a lot of staff and things like that. You need to let them know what you need to be comfortable because this is a big day for you and you're going to remember it for the rest of your life. This is the birth of your baby, and we want it to be as joyous and as comfortable as possible. Okay. Again, ask questions and don't be afraid to advocate for yourself. All right, so pain management. We're going to quickly cover some of that. You have options when it comes to pain management, usually depending on the status of your health, the status of the baby, and the status of your labor. There's a lot of variables here, and I've heard lots of stories where people will say, well, the nurse wouldn't let me do this or the nurse wouldn't let me do that. There's probably a good reason why the nurse wouldn't let you do that, and we're going to kind of talk about that so that you can have a better understanding of what's going on. And again, you'll be able to ask questions and advocate for yourself. So first of all, the first method of pain management is none at all. This is an option for people who really have their head wrapped around the process of birth. You've accepted and understand it, that this is going to be uncomfortable, but you're willing to go for it. You're willing to work through it. You have that mindset. That's a great option for some people. Um, Along with going natural, you can also work on focused meditation. That has to do with breathing techniques, guided meditation, all kinds of different things that you can do above and beyond that. That can even include massage, aromatherapy, music therapy, stuff like that. The other option is IV pain medication. Depending on your provider specifically, there might be different things that they can put through the IV. I'm not even going to name them because it's greatly going to vary depending on where you are. Another thing that you may have, depending on the place we're going to deliver, is inhaled nitrous oxide. This is kind of like a gas mask, and so when the contractions are intense, you inhale the gas. It kind of helps you get through each contraction one at a time. Another option is an epidural. This is kind of similar like how we make an IV catheter. A catheter goes in your spine at just the right spot, and there is a continuous infusion of medication that bathes those nerves and keeps you numb from a certain point down. Epidurals are a great if you're a high risk person, because if you're a high risk for a C-section, we can very quickly turn that into a spinal block. Just like how if you have your IV, we can very quickly put medication in there that we need to do what we need to do. Epidural is great for that reason. There are drawbacks to an epidural. There says there are drawbacks to all of these kind of things. We're not going to kind of get into those. I just want to make you aware of what they are. And then the final thing would be a spinal block. Like I said, that's a C-section thing. Instead of us putting the catheter in there and it's staying there, kind of like how an IV catheter does, the anesthesiologist finds the spot, puts the medication in, and then we lay you down and immediately do your surgery. All right, this right here is an electronic fetal monitoring strip. You are most likely going to be hooked up to a monitor, and it's going to be spitting out this paper or sending this information to a computer screen that your nurse is going to read to kind of keep track of your labor and your process and what's going on. So I'm going to give you a very high level overview of what's going on so that you'll understand kind of what these lines mean, and it'll also make you feel a little bit more engaged in the process. So let's start at the bottom. At the bottom here, you see there's lots of these little mountains, okay? Each and every one of these is a contraction from the mother. Now, I don't want you to misunderstand that even if you see this hill go up and beyond the 100, that has nothing to do with the rating of the pain or how intense these contractions are. If you have the little circle thing on the outside of your belly, all this is doing is just recording. It's just recording that it's happening. Some are hypersensitive and will record big old ones, and some are not, and they'll record little ones. The only way we know exactly how intense these contractions are and how painful they are is if your doctor would put an internal monitor. So that's a monitor that is going to go in your vagina and sits inside next to your uterus to actually monitor those. So unless you have an internal monitor, this does not record anything for us other than the timing, and the duration. So these contractions, they started kind of far apart, and you can see that they picked up here. So we time the contractions from the beginning of one to the beginning of the other. Each one of these these lines is 10 seconds. So we see that we have one, two, a couple minutes between those first two, and then when we get to the end here, these contractions are starting almost every minute and a half where they get on top of each other. So that's what that is recording down there. The line at the top where you see that it's kind of squiggly and then has an uphill, that's your baby's heart rate. Okay. So we want to see that your baby's heart rate has a little bit of what we call variability to it. We don't like to see baby's heart be a straight, steady line, kind of the way that we would expect we want to see our heart rate. Okay, so we want to see that the baby's heart rate is doing these things and that it's doing these nice little these lifts called exhales. That lets us know that your baby is really doing good and that everything is going well with them. And like how I said with the baby, like kind of like taking a deep breath before going underwater with some of these contractions when they get intense, that's what that acceleration of the heart rate is. Your baby's heart rate accelerates and that circulates a lot of that oxygen really, really quickly so that they're ready to handle that contraction. As you can see later on down here, there's a spot where there was a contraction and the baby's heart rate took a dip. That is a deceleration because the heart rate goes down. Sometimes it's okay, sometimes it's not. That it's kind of depending on a lot of different factors, so we're not going to get into that. But we want to see that your baby's heart rate has good variability and that it's moving around, and that lets us know that your baby is happy and tolerating labor well. And if you ask your doctor or your nurse, I'm sure that they would be happy to explain more to you when you're actually getting monitored, and it'll make a little bit more sense when you're experiencing it. All right, so pushing. When it comes time to push, that is a part where sometimes things can get a little spicy and overwhelming. I like to have the pushing conversation with moms when they are kind of trucking along during labor and they're doing okay and we know we're making good progress. Because the first time you hear some information, you don't really receive all of it. So I want to make sure that when you go to push your baby out, you are ready, you're prepared, and that you can do good, effective pushing. Because a lot of people are like pushing and they don't know what it is we're wanting them to do or what part of the body we're actually targeting. So we're going to talk about that. We're going to have a real conversation about pushing, okay? So first of all, it's not really like the movies. I have had my fair share of deliveries where the people are yelling and screaming and doing these things. But when you are just lost and you are not in control and you're just screaming and hollering and making all of that noise, a lot of things are happening. First of all, it's creating chaos, which is creating stress, which is creating cortisol, which is a stress hormone. That's not what we need. You're already going to have enough of that anyway from being in labor and the excitement of all of it. We want to make sure that you have a handle on the situation and that you maintain control of those contractions, that even though it hurts, you're still in control of your person and you are still maintaining. And it is okay if you need to make noise, but you don't want to be I don't know, off the chain for lack of a better word. As much as you need to, pull it in. And that is a great job for one of your support people is to bring you back in. I love it when the support person does it. You have a relationship with this person. If I'm your nurse, I've just met you. It's not quite the same me talking you down off the tree ledge as somebody you love. And so what you can do in that instance, support person, is remind them, you've got this. You are so strong. You've already come so far. We are almost there. We are at the end. There is no way you're going to fail now. I have complete faith in you. Build them up. Be their cheerleaders so that they have the invigoration that they need to get through this. Okay. So, first of all, you want to stay in control. Open glottis or closed glottis. So, I had a couple providers who used to argue about the way that we would have mamas push. So, we'll kind of get into the spot you need to push, but we're going to talk about the other part, and then get to the location that we're targeting later. Okay. Just follow me here. So open glottis is when you have an open throat when you're pushing. And you could be making noise while you're pushing, but it's more like a moaning and not like a screaming. So instead of you being more like, ah, ah, when you're trying to push, It's more like a throaty, chesty noise, and it's more like, that is open glottis pushing. Okay. Closed glottis pushing just means you're not making any noise when you push. So if you are pushing with your team and they're telling you don't make noise, they're wanting closed glottis because that will kind of maintain the pressure that you need in the area we need. If you are going to make noise, if you need to as you're pushing, make sure that it is coming from your chest, and that will keep the pressure directed where it needs to go. Whenever you're pushing, you should never feel pressure in your face. If your face is turning red, if you feel pressure here, this isn't where it's supposed to be. Again, this is in your body, and we'll travel down that road a little bit more too. Okay, counting or no counting. For some people, this helps them focus. For other people, it's not a helpful thing. So you're going to find out whether this is good for you. So we'll tell you, it'll be like, so take a deep breath and push. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Take a deep breath, and then we'll have you breathe, breathe, okay? Back on it. And we'll do it again. The goal is usually to get 3 pushes per contraction. We count slowly so that you focus, so that you're not trying to barrel through this. So work with your team and follow their directions, because the other thing is the person who's usually helping you, coach you on pushing, is the person who's helping at the business end of all of this too. And then we'll get to the point of, do you know what you're doing? Really? Really, really. Because sometimes I see women push for 2 or 3 hours and their face is all busted up, full of broken blood vessels. Their vaginal area is all swollen. And so now is the part we're going to talk about where you are pushing. The easiest way to describe it to you is you are going to push using the same group of muscles that you would use if you were constipated and very much trying to pass a stool. And I'm talking about the kind of constipated where like you have to lean back and really strain. You're not using your regular muscles in that point, you're using a different set of muscles. Think about that the next time you use the bathroom. The other thing you can do to start having awareness of this group of muscles and having a little bit more control is doing those Kegel exercises where you are tightening those muscles. You will feel your pelvic floor tighten when you squeeze in to do the Kegel, and you'll feel it release. Now your whole bottom should not be squeezing up when you tense to do this Kegel. It should just be your inner pelvic floor. Okay, so to review, the pushing muscles you're going to use are the muscles you would use to pass stool when you are severely constipated and you're really trying to push. They're also the same muscles that you control when you do a Kegel. So if you start trying to figure out how to control your Kegels and you start kind of figuring that out, and you use the bathroom, you are going to be so far ahead when it comes to push this baby out, because you are already going to know what we're talking about when we say push. And when you push on those muscles, your face should not be red. And when you push on those muscles, you will still be able to have a little bit of an open glottis and do those guttural noises, because when you do that, you'll also include your diaphragm in the process. Okay, so experiment with that a little bit so that you have a better direction and you don't end up swollen and looking like you've been through a fight. The other thing I want to mention about pushing is if you do not have an epidural, or even if you do sometimes, there's not a lot that the epidural will be able to do with the pain of actually delivering the baby. So again, it's important to wrap your head around that and have a pep talk with yourself that yes, this is going to hurt, but it is pain with a purpose, and it is going to get you close to meeting your baby. A lot of moms will experience when your baby is very, very close to crowning, what we describe as like the ring of fire. That's the inner part of your vaginal wall that's starting to stretch. We don't want you to just push the baby out. When the baby just, comes barreling out, there's a lot of risk there. There's risk for trauma to the baby. There's risk for trauma to you and the need for a lot of repair because there could be tearing. We want the baby to come out in a slow, controlled fashion so that your tissue can slowly adjust to accommodate and your baby can have a peaceful entry into the world. Okay, so delivery, the head will take the longest to push out. Okay, once the head is delivered, the shoulders and body pretty much just, you don't have to do anything for that. The head will come out, the doctor may or may not tell you to push, and that's it. When you are feeling that burning, push through that ring of fire, but push through it slowly. Don't just try to barrel through it, but just keep your same intention. Keep pushing. That's how you know you're almost there. So tearing versus episiotomy, it is always better for you to tear versus the doctor cutting an episiotomy if possible. It heals better. I could get into all of that. Just so you know, it is better to tear than to get an episiotomy in most cases, okay? If your doctor at some point tells you to stop pushing, it is very important that you stop pushing. Even if you're like, are you kidding me, sir? This baby is coming out. In order to stop yourself from pushing, you can blow or pant. When you're doing that, you can't bear down. Okay, so that's why they have you blow or pant so that you cannot be pushing. The reason that they're doing that is the doctor is very much going to support the underneath of your vagina as your baby's head is coming through to keep you from tearing so much. We want the baby's head to emerge slowly, okay? So that's when they'll probably ask you to stop and the baby's head will come out. When your baby's head is delivered up to here, your doctor is going to suck out the fluid from the nose and the mouth. They're going to check around the neck to make sure that there's not a cord wrapped around, and then they'll tell you push, and then the baby will come out, okay? The baby is ideally placed right up on mom's chest, skin to skin, while waiting for the placenta to be delivered, which can take a few minutes. Cutting of the cord, ideally cut it after 60 seconds. It might be sooner if there's something that they need to take the baby to go investigate, but ideally at least 60 seconds. More or less is going to have different outcomes, and depending on what you want to do with your life, they might be different. That is a conversation to have with your provider. After that, the placenta is delivered, and then your doctor may ask you to push again to have the placenta come out. I'm telling you, it is nothing like the baby. It is really no big deal when the placenta just comes out. After the placenta is delivered, the doctor is going to be taking a very good look at everything that's going on down there. You're going to have any repairs if you need them. When the baby and the placenta are delivered, at that point, usually the doctor will have you get some Pitocin through the IV because we want to shrink the uterus back down to its normal size. That placenta is about this big. It's about the size of a dinner plate. And now you have a dinner plate sized wound on the inside of your uterus where that placenta used to be. So it is very important that we shrink that uterus back down so that that wound size decreases and your bleeding will start to decrease and kind of get back in under control. This is when your recovery period will start. Your nurse will probably check your fundus, which is your uterus, about every 15 minutes. All right. So for your baby's first moments, when that baby is placed on your chest, your baby is learning how to breathe and take a deep breath. They've never breathed before because when they are in the uterus, they take practice breaths because they are encased in fluid. But when the baby completely comes out, they'll take a breath. And so they're learning how to breathe. And I can imagine it probably feels similar to breathing heavy on a cold winter's day. So that's why it's important that your baby is skin to skin and feels secure as possible with this transition. They are also feeling cold for the first time. They've never had discomfort. They've been comfortable and squishy, and now they're cold. It's very, very loud and bright and scary. You know, when you've never been around something before, it's scary. So it's so important that that baby is skin to skin with you. You start talking to your baby so that they know that you are still there. They'll still feel comforted. They can hear the sound of your heart. The baby's heart and lungs, their circulation is completely different inside than outside. There are holes that are opening and closing in their heart and lungs as they take a breath and do all of this. There's a lot of stuff going on. So this is why skin to skin matters. It's not just, some warm fuzzy thing that we're doing with your baby. Can you imagine having run a marathon? That's in the wintertime. That's kind of what's going on with your baby. That's why skin to skin is so important. It makes your baby feel safe. It makes your baby feel secure. On top of that, your heart rate will regulate your baby's heart rate. The temperature of your body regulates your baby's temperature. It also stabilizes your baby's blood sugar. I could go on and on and on. This is the crash course. Just so you know, skin to skin is important and continues to be important throughout your baby's life. When your baby is sick, even when they're 6 months old, skin to skin is a great thing to do to help your baby feel better. So your body is changing too. We talked about the big contractions to close up your placenta. The delivery of your placenta tells your brain to tell your breast to start making milk. What you would have in your breast right now is this really thick, sticky substance called colostrum. It is yellow, it is very nutrient dense, and it also works as a laxative, which is great for your baby's gut to kind of get that first poop called meconium out. So a lot of things are happening with you. Skin to skin also does things for the mama because it releases oxytocin. That is the love and bonding hormone. And that also that's the natural form of the synthetic pitocin that we give to contract your uterus. So the more you're snuggling with the baby, the more natural pitocin you have in your body. Breastfeeding also releases oxytocin, which is much needed to shrink the uterus. So it is imperative that moms and babies are together in this way after the baby is born. All right, C-section. Whether it's planned or whether it is an emergency, a C-section is the delivery of a baby through a surgical incision in a woman's abdomen, or like we like to call it, the sunroof exit, okay? Admission for a planned C-section is similar to an admission for labor with some added steps. So they'll do the consent form, they'll do the IV, they'll hook you up to the monitor, they'll do a cervical exam, they'll do all of that kind of stuff. But then they're going to shave any pubic hair you might have up at the top near your belly because they usually do like a low-lying incision. They're also going to clean your belly with surgical wipes. And ideally, if your facility can accommodate that, your baby still should come skin to skin with you after the baby is born. If that is not possible, then baby can do skin to skin with dad or some other adult. I've seen grandparents doing skin to skin with baby while mom was finishing up a C-section. And then as soon as mom is in that recovery room, you can do skin to skin with your baby and nursing in there. So your baby can do skin to skin with somebody else until you are all ready to receive that baby for your first cuddles. The golden hour is the first hour after baby's birth. Okay, we want to allow the baby to remain skin to skin with mom until after the baby has nursed. Sometimes this process can even take 2 hours. I know it's super exciting and everybody wants to pass the baby around and see the baby, but honestly, truly, it is very important for this bonding to take place. This was one of the best parts about COVID. There was nobody there. It was the new family bonding and starting their lives. And everything was starting off right. The breastfeeding was better, the bonding was better, the sleep was better. Everything is better when we start off on the right foot, okay? This is about the foundation of your relationship with your baby. This is setting the foundation for bonding. Sometimes things happen when things will kind of go sideways with the baby or with mom, and you can't do this. It is possible within the first couple weeks of birth to do kind of like what would be like a hard reset. So if your bonding period got interrupted because of some sort of an emergency, please do not fret. We can reclaim some of that time, and I would be happy to tell you how. Okay. The other thing is be patient with your baby. If you left your baby alone, they would crawl up and attach themselves to your breast with no help from you at all. And honestly, truly, this is the best way for it to happen. When we start meddling and we start manipulating the baby and shoving things in the baby's mouth and doing all of this other stuff on top of everything else that this baby has just been through, it can create an aversion to nursing. And I really do believe that this is sometimes why people have such a hard time nursing their babies, is because that first nursing was kind of rushed or hurried, or there's a lot going on and it kind of gets things off on the wrong foot. So please be patient with your baby. And if you need help, make sure that you ask for help. It's important not to really force your baby to do anything. And when you're in this more laid back position, it's okay for gravity to do its thing. Your baby can be on top of the breast. And it's fine. It doesn't have to look like that classical picture we might have in our head of cradling the baby. Your breast is round. As long as your baby attaches, it doesn't matter which direction the rest of their body is going, okay? All right, the recovery period is that first 2 hours afterwards. There's going to be frequent checks on the firmness and the location of your fundus. So every so often, your nurse is going to come and rub on your fundus. It's going to make it cramp and it's not going to feel good, but they're also going to check how much you're bleeding. They're going to make sure that you're nursing well. If you cannot nurse, for whatever reason, and it is your intention to breastfeed, ask for a hospital grade pump. This period of time releases the most colostrum in the immediate hour or so after birth. After this, pumping really is only for stimulation, not for milk collection. Because your body knows you just gave birth, it has that big reserve there ready to give your baby. And we can get that with a pump in that first hour or so. But after that, until the milk transitions, sometimes that colostrum just gets sticky, stuck up in the pump. Okay. And if you need to talk to a lactation consultant, please ask to speak to a lactation consultant. If you had a vaginal delivery, you can eat and drink as permitted. If you had a C-section, they might allow you some ice chips. Kind of depends on what the protocol there is. Up to the bathroom as your care team permits. They are not going to want you getting up by yourself the first time or so, at least for sure the first time. So if you feel like you have to use the bathroom or you want to get up, please put on your call light. Please call your care team. I guarantee they want you to call them because they do not want you to fall. Okay? So your job in this time is not to be hostess or entertainer to anybody. Your job in this time is to recover and get to know your baby and settle into your new role as a parent and to just enjoy it as much as you possibly can. So we're going to talk a little bit about some normal newborn behavior. The first thing I want to talk about is cluster feeding, also known as second night syndrome. A lot of people will start to panic and think that they can't nurse their baby because, oh my gosh, my baby is all he wants to do is eat. I fed him an hour ago. He's still hungry. Oh my goodness, what's going on? Well, that, my friends, is normal. That is what a baby is created, designed, and driven to do. It is only because we're used to more seeing people doing bottle feeding and formula feeding that we don't know what normal breastfeeding behavior looks like. So I'm here to tell you, just so you know, the first couple days after your baby is born, all they're going to want to do is nurse. And it's not because you've done anything wrong. It's not because you don't have the milk to provide for your baby. This is what drives your milk supply. Milk supply works on demand and then supply. So your baby has to put in that order for demand in order for your body to create that supply. And that's why we welcome and want your baby to frequently nurse. They'll get better at nursing. They'll tell your body to make more milk. And what you do in the first couple weeks of life with your baby, as far as your milk supply is concerned, really determines what your lifetime of milk supply will look like. It's very, very important. Okay, so please don't let that surprise you. They're also going to want to suck on their hands. That is okay. Please let your baby have their hands. If you're concerned about your baby scratching themselves, you can take a nail file and just file their nails down. Your baby had access to their hands the whole time that they were growing in the womb. Sucking is a source of comfort for babies. That's their built-in coping mechanism. So they're going to really want their hands back. And how would you feel if you had something that used to bring you comfort and then all of a sudden somebody took it away from you right in the middle of a great big transition? It would make that transition a little harder. So it is okay if your baby sucks on their hands. They're also going to want to be held. Everything that they've ever known is completely taken away from them. They've never been cold. They've never been hungry. They've never had to breathe air. They want to be comforted. And it's okay for you to comfort and hold your baby. It is a myth that you can spoil a newborn. The newborn doesn't know what's going on. The newborn just knows how it feels and that it needs to be comforted. And what we have found is these babies who get this love and support in the beginning, they get that foundation, the good foundation. These kiddos are more independent and well-adjusted in the future. So it is important. It is okay for your baby to cry. Crying is a superpower. Crying is how your child communicates with you and lets you know what they need. And the more you pay attention to your baby's cries, the more you're going to be able to actually identify what they need without playing that guessing game roulette where, like, okay, are you hungry? Ah, okay, do we feed you? Oh, do we change you? I'm telling you that the more you pay attention to your child and the noises that they make, the more you're going to really understand what your baby needs, and it's going to make life a lot more peaceful for the both of you. So, sleeping for short periods of time. Your baby's metabolism is not made at this time to sleep through the night. Most babies are actually physically and metabolically incapable of sleeping for these long 6 to 8 hour periods until they weigh at least 10 pounds. So, this little guy with a tiny little stomach is not going to be able to hold food that long to maintain a sleep like that. Okay. So we are going to expect that they're going to be sleeping for short periods because they're tiny, they get little meals, little sleeps, and they just kind of repeat the cycle. So this is important when what they tell you. Sleep when the baby is sleeping. When your baby goes down for a nap, take a nap. Because you know what? When you wake up later, those dishes are still going to be there. But sleep, you can't always get that time to sleep back, but that mess will be there. Okay. So make sure that you are resting, make sure that you are recovering, make sure that you are sleeping as much as possible. Here's another thing about babies. They can smell their mothers. So with the cluster feeding, sometimes it gets to be a lot, to be perfectly honest. You know, you've just had a baby and you've gone through labor for who knows how long, like you need a minute. So even though the most hospitals encourage rooming in, it is okay to ask your staff to take your baby for you for a short amount of time if you need to sleep, especially during this cluster feeding period. I have found in my years in labor and delivery that during this cluster feeding, after a few cycles of this, mom's been doing this for about 3 or 4 hours, she needs a break. The baby is fed. The baby is just going through the anxiety of being born. And so what we'll do is we'll tell the mother, go ahead, you lay down, get some sleep. I'm going to take the baby with me. We take the baby, swaddle the baby, hold them, give them some love and comfort. Baby falls right to sleep. Why does this happen? Because they're separated. When the baby smells you, can you imagine that they are driven, that they are homesick? They are homesick for your womb. So please don't be surprised that your baby is upset like this because they're homesick. So what can you do? We can ease the pain for both of you. You can get some sleep for yourself. We can take the baby. They're not that in that constant, reminder of missing home. They go to sleep, and once the baby is good asleep, usually after like 20 minutes or so, we'll just roll the baby right back in so that you both are able to fall asleep, but we're still doing the rooming in and keeping you together. And you can do the same thing at home. Go into a different room, put some earplugs in, put some white noise on so that you cannot hear your baby cry, and let somebody else calm your baby down for you. And another parenting pro tip is please don't micromanage the way that the other people in your life take care of your baby. I know that you are the expert because you are the baby's mother and you want to tell them to do this, 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 and this. But when you are constantly micromanaging somebody's technique, it undermines their confidence. So even if it's driving you crazy, if possible, just put some earplugs in and let them figure it out. Because if you give them the time to grow, they'll figure out how to soothe the baby in their way and it'll be better for everybody overall. Okay. All right, so how much does my baby need to eat? The baby needs to eat at least 8 to 12 times a day for the first 3 to 4 weeks. If you are bottle feeding or formula feeding, if you're pumping, giving breast milk, or you're giving formula, that is going to be about a half an ounce to an ounce, 15 to 30 milliliters, about every 2 hours on day one. And you can go up to maybe 2 ounces day 3 to 5, because that would be about the time your breast milk would transition. Okay. And then by 1 month, feeds should space about every 3 to 4 hours during the day. It's very important that when we're bottle feeding that we use paced bottle feeding. Babies don't know how to regulate very much when they come out the womb. And when they're learning how to eat, they have to coordinate sucking, swallowing, and breathing. And most bottle nipples just drip. When you hold it upside down, it's drip, 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 drip. Well, your baby's trying to protect their airway. So they're just going to keep swallowing that milk or that formula so that they can breathe. And a lot of parents will be like, oh, look how hungry they were. They weren't really hungry. It was constantly dripping in their mouth. So they ate this big meal. And then usually what happens is a couple minutes later, they'll throw it all up. So it's important to teach your baby good eating habits from the beginning so that we're not used to constantly having a very big, stretched, overfull stomach, because that leads to patterns of overeating in the future. What about diapers? So the first day of life, your baby might not go to the bathroom for you at all. We expect maybe one pee, possibly a poop. They're going to want your baby to poop before they leave the hospital. Usually we see that on day 2 to 3. And especially for breastfed babies, it can really start going that every time you feed your baby, you'll have a dirty diaper to change. Okay. Diapers will begin to increase as your baby is getting used to this. And like I said, it'll get to the point where you can expect at least 10 wet diapers a day and maybe even a dirty diaper every time your baby eats. Babies who are formula fed, they may go once a day. It just kind of depends. After a few weeks, you'll start to see what is normal for your baby. And here's a little color wheel from Medical News Today about baby poop. It varies. Okay, so this first one, this black, it's like a black, very dark green. That is normal in newborns under a week old, because that is what we call meconium. That is everything that they've kind of ingested during their time in the womb that will come out, and then it will be kind of this greenish color, a lighter green, and then it transitions to yellow if you're breastfeeding, and it kind of stays like this green or brown if you are formula feeding. If you are combo feeding, it is normal to see both streaks, rainbows, all kinds of stuff. You'll start to see what is normal. We never want to see light or clay-colored stools, and we never want to see anything red. After your baby's stool has transitioned, you don't want to see that meconium color. If you see that again, you want to let your doctor know. Okay, baby feeding 101. So I do not have a particular stance on breast milk versus formula, except for it is very obvious that breast milk is superior, and if you can breastfeed, you should. And if you can't, okay, let's do the best we can. Any breast milk you can give your child is better than no breast milk at all. So please do not let anybody ever make you feel bad about the way that you feed your baby, because every day is a different adventure. And sometimes we have home-cooked meals, and sometimes we go through McDonald's drive-thru, because sometimes we're just trying to get through the day with as much love and patience as we can muster, and that's all right. So please, when you make decisions about feeding, do not let other people bully you into a decision one way or the other. Do what you want to do. Do what works best for your family, okay? Breast milk is healthier than formula. If you can give your baby breast milk, please do. If you're not able to, for whatever reason, it could be a physical reason, it could be an emotional reason, it could be whatever. If you can't, that's okay. When you do feed formula, please never, 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 never water down your formula. There are organizations out there like WIC that help get you supplemental formula. It was never meant to totally cover all of your formula. So if you're counting on WIC to provide all the formula you need, I'm letting you know now that it will not. Please do not water down your formula. It has major health consequences and can even lead to death. So please do not do that. And when you are using water, if you're going to mix the powder, please always use clean bottled water. Make sure that you keep your formula cans safe, enclosed, that they're not going to be able to be opened or tampered with by, like, other toddlers or siblings around the house. Please keep your pumped milk safe, safely store it. There are breast milk storage guidelines so that you want to make sure that that is safely stored. And then again, be cautious of overfeeding. Even if you are feeding formula, you still don't want to overfeed your baby. And use paced bottle feeding so that your baby can learn how how to self-regulate the food that goes into their body so that they learn to stop eating when they're full instead of waiting until they're overfull, and sometimes throwing up for that to be the signal that they're done. So as far as breastfeeding like a pro, if you want to do that, I highly encourage that you check out some of these videos I'm going to put in the description box below, especially hand expression. Hand expression is great because you might find yourself engorged somewhere and you need to get that milk out of your body so that you can be comfortable. Sometimes you're too engorged to latch the baby on, so you can need to be able to hand express to relieve that. So hand expression is super important. That is also a motion that you should be doing while your baby is latched on and eating, to very gently do those hand expression motions. It moves the milk, it keeps the baby interested in the feeding, and it helps you empty your breast better. Your milk will transition on day 3 to 5. This is different for everybody. All of a sudden, you might wake up from a nap and whoop, you're engorged. Ibuprofen will help with that. You can use ice packs and make sure you continue feeding and completely empty your breast so that you continue to make milk. You also, if you're going to pump, you want to use a technique called hands-on pumping. That is when you are doing massage in conjunction with the pump. When you do that, you get at least 50% more milk every single time. You also will get a better milk supply and maintain a better milk supply because, again, with supply and demand, you are completely emptying your breast doing that massage. You cannot completely empty your breast if you just stick the pump there and wait for 20 minutes. It will not happen. So this will help make sure that you have a fantastic milk supply. It is also imperative if you're using a pump to make sure you're using the correct flange size. The flange size is the size of the pump part that your nipple goes into. If it is too big or too small, it will directly affect your milk supply for the worse, might even cause some damage to your breast. And the other thing is to make sure you're using the correct suction strength. Using the correct suction strength also will determine the efficacy of your pumping. And so if you really want to get the most out of your pumping and you don't want to spend all day doing it, it is imperative that you have the correct flange, you know how to set your pump at the correct strength, and that you are using hands-on pumping. That is something that I could always do a virtual appointment to discuss. And so again, let your people support you. Your job is to rest. If you're nursing, let others change and play with the baby since mom does all the feeding. You can nurse the baby, hand the baby off for burping, and then give the baby back to eat on the other side if that's what you want to do. Make sure that you involve the older siblings in the care of our baby. Make it personal for them. Let them have some ownership of it. And, you know, when you call the baby our baby, it creates a team environment instead of just, you know, the baby, the other. It's a lot less of an us and them. And you know, when your friends come over to visit you, let them wash your dishes, let them wash your clothes, let them run the vacuum for you. You are not the hostess. You have just delivered a baby, and you are still growing and nurturing this child. So your job is to rest if at all possible. Please make good use of the support around you. Another thing that's really important to talk about is how do you manage difficulty? This is a very happy and joyous time, but sometimes it can cause a lot of strain on relationships. It is important to do a self-check-in before this happens to determine, like, how do you manage difficulty? How does your body respond to stress? Do you start to kind of like physically respond? Are you rough with the things in your environment? Do you get loud? Do you yell when you're stressed out? Do you shut down? What do you do when you're stressed out? And what do you do in response to that? How do you calm yourself down when you're stressed out? Do you have an action plan for that kind of a thing? If not, it's important to start thinking about that. And recall times you've been around a crying baby. And how did it make you feel? Did you have no response to it at all? Was it just background noise? Or did you notice that you were feeling like a frustration in your body? Were you feeling a physical response to it? It's very important because your baby is going to cry. And there are going to be days when your baby's going to cry and you can't make your baby stop. And what are you going to do on those days? Those are very hard and lonely times. And it's important to make an action plan for when that happens. It's okay to put your baby down in their swing or in their crib and let them cry. Walk away as long as they are safe and let them cry. You can go take a minute. It is okay. you can put your baby in the car and go for a ride. There's lots of other suggestions. There's things that you can do, and there's resources for this. Okay. So make an action plan for hard days and put it on your refrigerator. I know that this sounds, kind of basic, but I'm absolutely serious. When days are hard, I can and make a list of like 5 things that you can do to make it easier. Because you can't think when you're stressed out. You can't problem solve when you're stressed out. And so the thinking and the problem solving is already done for you. It's right there on the refrigerator. I can go do these things to kind of help mitigate my situation. This way you're not powerless and you already have resources you can tap into. Another thing that's important to do is understand your baby's crying a little bit more, especially in the first couple months. And that would be from a place called the Period of Purple Crying. They don't really call it colic anymore. It's more the Period of Purple Crying. It's an acronym. That's a great resource to kind of get some suggestions and also give you more information on crying and what you can do in those stressful situations. I know of at least one baby personally who could have been saved from the stresses that come from this. It is not monsters and criminals who shake their babies out of frustration. It is normal people like you and I who are overtired and overstressed. And the problem is once you cross that line, you can't take it back. So that's why it's important that you have all these tools and all these buffers you need so that you don't ever get to that place. If you, along with your action plan, I would suggest you put on your refrigerator the Crying Baby Hotline. This is a hotline, so it's available 24/7. It is staffed. There is a person who will speak to you when you are about to lose your mind over this crying baby. Okay? Put this number on your refrigerator. Somebody will talk you off the ledge. There is no shame in this. We have all been frustrated by a crying baby if you've ever had a baby. And if they're telling you that they've never been frustrated by their crying baby, they're lying to you. Everybody gets frustrated by crying babies sometimes. It is okay. What is not okay is sometimes the way that we respond to it. So we're going to respond appropriately and it will be all right. And it will be one of those things that you got through. And then you'll be able to help other people through it. There's also a Fussy Baby Warm Line. This is available 9 to 5 Central Time. Let's just say, hey, my baby is always crabby and I've tried X, Y, and Z. Talk to somebody. They can give you more suggestions on how to make this a little bit more calmer and peaceful for both you and your baby. All right, safe sleep. What do we need to know about safe sleep? Babies should always be placed alone on their back with nothing in their safe sleep space. Now, what is a safe sleep space? A safe sleep space is boxed in by bars like a crib or a pack and play or any other designated infant space, not on a bed, not on a couch, okay? Use a swaddle or a sleep sack, not really a loose blanket, so that the baby can't pull any of that over their head. And safe sleep also includes sleeping in the same room, but not the same bed. So if you want to nurse, it is absolutely great to nurse laying down. You can relax. If you are feeling drowsy, have another adult hang out with you in your house or even an older kid. Like, hey, I need you to check on me and wake me up if I fall asleep. As long as these activities are supervised, it is safe to do these things. You just don't want to fall asleep. This is another thing where we want to think ahead and have our action steps so that we don't ever cross a line we're not able to come back from. So if you're feeling drowsy, ask somebody else to take the baby for you. When you're in the hospital and you're feeling drowsy, put your call light on. Like if you're laying in your bed, you're holding your baby, you're feeling tired, you don't have to get up. Put your call light on and say, I'm feeling very tired. Could you put my baby in the bassinet for me? They would be happy to do that for you. Okay. Car seats. All right. A lot of hospitals will not let you leave unless you have a car seat, and most states instruct parents to keep children rear-facing until age 2. Please do. I could get into all of that, but again, this is the crash course. But what you need to know is it is the safest, best thing for babies to be rear-facing until age 2. People will get on about their legs and all this other stuff. Your baby can do their legs crisscross, applesauce. They can do all kinds of stuff. It is better for them to be rear-facing. When a child is in a rear-facing car seat, the straps should be at or below their shoulders, meaning the hole that the strap is going to go into the car seat should be right at their shoulders or below, never above. If you put your baby in the car seat and the strap is like this, you need to adjust the strap so that it is at or below the baby's shoulders. The chest clip should be right in the middle at the nipple line, and you do a pinch test to make sure that the straps are tight enough. So you make sure that they're at the right place at the shoulders. You'll put them in, close the chest clip. You can put your hand behind the chest clip and pull the strap to tighten. And you want to make sure you're not able to pinch any of that webbing. If you're not able to pinch any of that fabric strap, you know that it is tight enough. And guess what? There are a lot of kids that do not like being in the car seat. A lot of kids will cry when they're in the car seat. That is normal, that is expected. If you put your baby in the car seat and you don't feel confident with picking their car seat up and lifting them up over your head like this, you have not installed them securely in that car seat. So that's just like a little crash course on car seats and how you can make sure that they are safely installed. Another resource that I'll have below is safekids.org. You can find a car seat tech in your area. There are a lot of places that are permanent fitting stations, which means you can show up there with an appointment and they'll inspect the installation of your car seat and give you further information. All right, so that is the end of our very quick crash course and welcome to parenting. I hope that this has been a wealth of information for you. I also hope that it has inspired more questions. If you have more questions, please reach out to me via email. My email is stacy.sanchez@havalaparenting.com. That's STACY.Sanchez, SANCHEZ @HAVILAH parenting.com. And again, check out the description for more helpful links and resources. It has been my absolute pleasure doing this for you, and I hope that you have a safe and peaceful delivery. Be well and reach out if you need anything. Have a fantastic day.